and this is polycystic ovarian syndrome, which I won't go into all of that much, but sometimes they can be relatively solid with few obvious cysts. This patient came with acute left pelvic pain, and this is what her left ovary looks like. It was absolutely huge. And though there's no focal abnormality, you would certainly argue that there are areas of abnormal echogenicity, increased echogenicity here and here. And so not surprisingly, and most people would think, as did the person scanning the sonographer, that this patient likely had ovarian torsion. There were a few foci of flow, and we were able to get a little bit of low-level flow. These are the images that were initially presented. And you notice the time, this was at 1:43. Upon re-imaging, however, a little more than a quarter of an hour later, there was significant exuberant flow, much more flow in the ovary, relatively high velocities, and very low resistance. So this is a large ovary. Ovarian torsion is the diagnosis, but it's a torsion and detorsion that was going on here. So not that you should be led into a pitfall of thinking everything was actually all right because there was flow. So for ovarian torsion, the most important finding is the enlarged ovary, which might be in an unusual location. The echogenic areas are probably secondary to hemorrhage, and there can be an underlying mass. Flow is not necessarily the key finding. You may find flow. Do not be dissuaded by finding flow. And the last group of cases are some M&M cases, and several of these are actually very large masses which can be easily missed or mistaken. These are the initial images brought by the sonographer on this patient, and who was thought to have a very large uterus. And it was unclear to the sonographer if this was a fibroid uterus or this was adenomyosis. And you can see the measurements sagittally and transversely with the labels that they were presented. Further imaging, the bladder actually filled a little bit, revealed that this is probably the main body of the uterus, and there was a very large hypoechoic mass. We tried transvaginal imaging, saw the uterus, and it was hard to tell if this mass was arising from the uterus or was separate from it. MR is the best study for problem solving, and this was what we had suggested. This turned out to be a very large, solid mass, quite separate from the uterus right here. And this was a large ovarian fibroma. And these are the ones that may sometimes be difficult to distinguish from an exophytic myoma. This study was also came into our M&M pile. It was initially interpreted as a normal transabdominal study. Here's the uterus in transverse, here's the uterus in sagittal, and this is the urinary bladder. However, this urinary bladder seemed awfully round, and if you look carefully, you can see a little echogenic line that you might think was some odd septation or debris. Further imaging showed that actually this is the bladder, and this is a very large ovarian cyst which was compressing an almost empty bladder. So once in a while, a large cyst, empty bladder, and the two can be mistaken. This was a novice sonographer, somebody who was very new, and she brought these images, and they are labeled as they were submitted to us. This was thought to be a transverse view of the uterus, though it was unclear where the border of the uterus was. This image was labeled left ovary, which it was with a follicle, and this was labeled right ovary. If you look a little more carefully here, you'll notice that this is the aorta and this is the inferior vena cava, and this structure doesn't really look like an ovary and doesn't have any follicles. In addition, we were looking at this area here where we couldn't see the border of the uterus, and was there something on the right side that was kind of echogenic? MR imaging was done in this patient, and you can see the echogenic mass in the right adnexa is actually a classic dermoid. And here is some further transvaginal imaging of it. This is a blown-up image of what was labeled initially as the right ovary. And what it actually represents is the intervertebral disc. This was a thin patient, and sometimes as you scan through, you can get vertebral body with the shadowing from the bone. And then if you happen to image right where the disc space is, you can see it as a round hypoechoic structure. And so she couldn't find the right ovary in the pelvis and just went up higher and higher until there was something that seemed to be the right size and shape and labeled that the right ovary. So the masses that are actually the most common, amongst the most common to miss are large dermoids that do not have any classic cystic component. Here's another one. This was initially thought to be a fairly normal pelvic ultrasound, bladder, uterus, and this was interpreted as bowel gas above the uterus. And the clinicians felt something, and actually there's a huge dermoid sitting here above the uterus. This is not bowel gas. Here's another one. Is this an adnexal mass? And what actually does it even measure? The borders are so indistinct in this situation. And again, this was another very fatty dermoid. So sometimes they can blend in to the fat everywhere around them. And just to remind you that the fat components, that the CT and the ultrasound can somewhat be a little seemingly discrepant. This looks more fluidy to us, and this is shadowing. On CT, this is fat in a liquid state in the body, which is warm, and this is also a little ball of fat, but with an echogenic rind around it and shadowing, and we can't not appreciate the fat inside. The last case that I'll show you is this one, interpreted initially as a cystic adnexal mass on the right with solid components and cystic septated components. And actually, upon further imaging, you can see that these are both ovaries. This is an ovary with follicles. These are both ovaries sort of tethered together in the cul-de-sac with cystic areas and septi around them, connecting them. There happened to be a corpus luteum in the right ovary, and this is a classic peritoneal inclusion cyst. These are not actually true cysts, but there's fluid trapped in adhesions around the ovary. Usually these patients have a history of prior abdominal or pelvic surgery or trauma or endometriosis, and these should not be diagnosed as a tumor. So, in summary, this is our advice based on a varieties of mistakes and problems that we've encountered. Be familiar with uncommon variations of common entities, because those will be the things you'll see more frequently, such as cystic or fat-containing myomata. Consider ovarian size either too small or too large as a diagnosis, even if there is no focal abnormality. Always ask the patient if she's had a cesarean section, and be prepared to understand the appearance of the scar and its associated abnormalities. Remember, there is more to the pelvis than the uterus and ovaries, and you may often make very significant diagnoses related to bowel, fallopian tubes, ureters, and even the bladder. Recognize the issues related to large abnormalities such as cysts and dermoids that may extend out of the pelvis, and always appreciate the limitations of pelvic ultrasound. And if things just do not make sense or cannot be completely evaluated, suggest another study, which in our situation is usually MR. Thank you.